Hello, and welcome to Riverside Reflections. My name is Denise Bananas. I'm the Associate Vice President for External Affairs for St. John's Riverside Hospital, and I am your host today. Today, we are welcoming Dr. Suzanne Greenidge, who has been an obstetrician gynecologist with St. John's for 30-something years. Yeah, I know, it goes fast.
Yes.
But so today we're gonna have a great discussion. Thank you for being with us today.
Thank you for having me.
Of course, it's our pleasure. So, Dr. Greenidge, what I want to talk about a little bit today, we have an initiative. It's a Black Maternal Health Initiative. And can you tell our audience a little bit about what that initiative is about?
The Black Health Strategic Plan, basically, is a plan that was devised by Ron Cordy, the CEO for this hospital, as well as Cheryl Brannon, Assistant International. And what it is initiatives, maybe about 15 of them, which we have formed together under this one umbrella, this whole plan, to basically improve Black maternal outcomes for Black women and their birthing experience.
So obviously there's a need.
Absolutely.
So can you talk a little bit about the need for these kinds of interventions that you're working on?
Basically, Black women have a higher rate of death and mortality and morbidity, basically in New York State, up to 6 times the amount of white women. So we need an initiative to combat that. And basically during pandemic, it started to go up. So for example, in 2019, we had maybe about 750 deaths, in the United States. Then in 2020, during the pandemic, it went up to 800 and something.
Wow.
And by 2021, we were at 1,200. And to make it even more specific for Black women, there were less Black women delivering, and they started rising in terms of their mortality and morbidity, i.e. why the initiative and the plan was formed in 2021.
Okay, so let's talk about the role that the hospital is playing in these initiatives. First of all, what are the interventions that you're focusing on as to try and improve that outcome for Black women?
So basically it's multifaceted. We are really, just to start, it's about the patient. We're trying to make sure that we bring the care to the patient. We have surveyed patients to find out what their experience is, and what we're trying to do is make sure that our care is patient-centered. Yeah. We really want to make sure that the patients are involved with their care, and we want to make sure that they are helping lead us. Not only the patients, it's about the staff here at the hospital. It's about the hospital itself, the institution. We want to make sure that we're anti-racist. We don't want to have racism part of our program here. We want to be intercultural. We want to be all-inclusive. We want to involve everyone. So that's the institution. Then the staff. We want to involve the staff. We want to make sure that our staff understands the way they feel and that they can sometimes give off biases towards patients. So implicit bias is also training for the staff, and also collaboration, right? We want to collaborate. We want to collaborate between the physicians, the staff, the patients, and the institution.
Okay, so all of those factors that may have contributed nationwide to the mortality of Black women going up, is there something specific, like I'm going to just say it. Is it our C-section rate that we're focusing on? How are we clinically improving that care to ensure that women have the best experience here, but also have the lowest mortality?
Correct. So one of the things that we did was we surveyed the patients. We made sure that we understood where they were coming from in terms of what they wanted. And then we did research. We have dashboards that we're able to measure lots of things. And we also measure our birthing outcomes. So we're measuring how many deliveries we do, what percentage are Black women versus white women versus other races, are Black and brown women.
Yeah.
We measure all of that, as well as we measure our C-section rates. So the goal is to change what we're doing now, obviously, right? We can't keep doing what we're doing, which is we have high section rate throughout the United States, up until 40%. Our section rate overall is in the 30s.
Okay.
We're at 30%.
So that overall though is about two different numbers. That's primary and secondary C-section.
That's total section rate.
Total section rate. Okay.
So then when we get into detail, now we want to know about our section rate among our nullips, or the women that are first delivering. So it's about those who first deliver, whether their head is down, or we say vertex, right? And whether they are a vaginal delivery, that is what we measure. So it's called NTS, and they're at term also. So we're not measuring really, and we're basing this over all the hospitals. This is a collaboration that all birthing hospitals in New York State has to participate with. So we all have to present this data, and basically our data is too high. Overall, it's 40% overall. So we really have to put a focus on it. We have to put this focus, and we have to measure it, and we have to be able to decrease it. And the goal is to try to decrease it by 2027. And what's the amount? 23% is what we're looking at. So the goal is to get our primary C-section rate to 23%. 23%. From about 25, 26? 30, 40%. Primary is 30, 30. Yeah, oh, wow. Correct. Okay. Yeah. All right. Well, 23% for primary if you're including everyone. But remember, we're talking about those who are at term, the NTSV, that's the 23%. That's what we're trying to get to, 23%. Okay. So and that number is not just Black women who are delivering here. That number is every woman. So honestly, all women are going to benefit from the focus on the care and the care delivery. All women will benefit. But when we specifically talk about Black women, we're even higher. And that's where the problem is. Okay. So although we may be in the 30s, Black women may be in the 40s. Okay. So that's where we have to have equity. We have to make sure that we're doing all the right things. I.e. why these initiatives are important, and why we need to bring this forth to everyone. All right. So can you talk a little bit about, so you went into this process, the OB physicians that are on staff here, how are they involved, and what does that look like? We started this in 2021 during the pandemic, which was really great. We formed, in November, we formed a physician focus group involving all our OBGYNs. We partnered with them to present all the problems, and then to offer or ask what kind of solutions they may have, and problems that they were encountering. Some of those things were that, the facility, we wound up getting a grant to improve some of the things that we can do here at St. John's, which is wonderful. Yeah. We're about to get a brand new labor room, second labor room, which is going to be brand new. Our rooms are going to be updated. Right. So this is some of the things that physicians, when they got together, they said they wanted a second OR so that we can have access to doing urgent sections without a problem and not having to turn over one room. So we're getting that by the grant, and that was brought together by the efforts of the hospital securing the funds for that. Right. So another piece of this was the Intercultural Development Inventory training. So can you talk a little bit about that and who participated? Because I think the docs also participated. Correct. In that. Yes. So the staff participated. They were able to ask questions. What is it? So tell me what it is first. It's Intercultural Development Inventory. So it's basically taking stock of your own biases and finding out how you feel with culture. And they ask you questions. So it's a questionnaire and insight into what you feel. Okay. So in terms of the hospital wound up doing it, and I found it to be very exciting for specifically our labor room nurses, because all of a sudden, after they got insight into themselves and they were able to understand culturally what they felt and how it impacted. And how different it is from the patient. And how different it was for the patient, bring it back to the patient. Right. They then started to do things together. All of a sudden, I started seeing jackets that said labor and delivery nurses. And, it brought a togetherness. A team. Yeah, a team approach for both all the nurses and then as well as the doctors. We did our own. Right. We had our own segment where we were able to ask questions and to just find out what our cultural beliefs are and how we're going to take that for the future.
That's very interesting.
Both groups wound up doing it, and I think it was very, very good for the future.
There was a focus group for physicians also. What was that about?
Yeah, so it just started talking about the focus group was basically to help decrease the amount of C-sections. That's one aspect of it, but also how we're delivering care to our patients. What's important? So the physicians realized that what's important was, preconceptual counseling.
Right.
We have to get to the community
Before
they get pregnant.
Right.
So we are in the third largest city in New York.
That's
Yonkers,
true.
correct?
Yes.
So part of our problem here is our diabetes rates,
High.
our hypertension rates,
High.
our obesity rates,
High.
our preeclamptic rates.
Yeah.
We can go on and on, okay?
Yeah.
And because of that, we said, well, where can we make a difference? Well, we're making a difference by partnering with our community partners, such as Assisted Assistant International with Cheryl Brannon. And
helping to get the information out and the education.
Get the information out and going into the community and finding out what the community needs. And that's why pulling them into this partnership was very important, right? So we needed to make sure that we can get to the community and let them have the information that we didn't think they had. For example, we have a preeclamptic campaign, basically bringing the information in their language, not in our language.
Right, so they understand what it is. And
then the CARES committee.
Proactive about their care. And the CARES committee that St. John's
CARES
has.
committee.
Yeah.
We have a CARES committee here that is so out there.
So their mission, by the way, is to pursue activities that help build trust in the communities of color, so that those folks in those communities will feel comfortable coming here and actually being empowered to ask questions.
Yeah, I started on the CARES committee.
Yeah.
And just getting out to the community and making them aware. We have the bicycle campaign, we have the food, the donations, all these things that help show the community that we are here for them, right? And that we're here to partner. So by partnering with them, we can then give them the information. And they'll be accepting, right? Because part of the problem for Black birthing people is that the trust isn't there. And we're here to make sure.
That really came to the forefront with many people during COVID.
Correct.
Yeah.
The food insecurities, the social, determinants of health, right?
Yeah.
Food insecurities, financial, job aspects, all these things that we realized that was even worse in the pandemic. So the CARES committee got together and went out into the community and helped the community.
Right.
So that shows that we are here at St. John's for the community. So we can partner together. So then when we try to give them the information about preconceptual counseling, and you need to reduce your weight and you need to have your diabetes under control. If you do have it, make them aware of gestational diabetes, all these things, they will listen to us.
Yeah.
They will trust us.
And
they will partner
take
with
better
us.
care of themselves and be informed
Before they get pregnant.
So there was another piece of this project on the creation of a dashboard.
Correct.
And can you talk about that data and how it's affecting the physicians here? Yeah.
So that data is so important because we never were able to see what our data was. And, in terms of individual, we would see the whole group. Well, this is what your stats is, and here's your normal deliveries, here's your primary section rate. But the dashboard, we can really play with it culturally. We can section it out for all Black women and see, well, how many Black women am I delivering last year?
Right.
What were their diagnoses? So the dashboard tells us in terms of your NTSV, again, the ones that are first delivering and at term, what was your diagnosis for doing the C-section? Did you do it because the patient failed to progress? Did you do it because the tracing was bad? So as a physician, we could really play with the dashboard and see individually and understand, maybe I shouldn't have done that elective C-section on this patient. Maybe I should have pushed that patient to try vaginally.
Right.
Okay, because this baby was 8 pounds. And maybe I could, and that's part of us getting to the community, letting them know that it's okay to try to have a vaginal delivery and not say that I just want a C-section. Of course, there are reasons why we have to do C-sections. We have to keep that in mind.
Right.
That, for example, babies that are very, very big, that may be a reason that we have to do C-sections. Patients who are severe preeclamptic with severe features, as we say, they're in trouble and they're remote from delivery.
Right.
We have to. I just had one the other day. I had a patient, she was blind when she came in.
Oh, no.
She could not see. Her blood pressure was 200s over
Lord.
1 something.
Good time to call that.
And that's not a patient that we
No.
can try to get a vaginal delivery for.
No.
So we also have to let the community know that
there are things
reasons why we have to do it. We don't want to do sections. We want to have vaginal deliveries, but we want to have it safe, and we want them to partner with us and give us what they want.
So this is all very interesting. And there was another piece of this. It's called the Patient Reported Experience Measure. This is really about what's important to our patients.
Correct.
So can you talk a little bit about that survey?
Yes, the Prem Survey.
Yeah.
So our goal with the Prem Survey was basically to have, when we first started, we had low numbers. Patients weren't filling them out.
Yeah, about 8% filled it out. Now it's up to 80.
Now it's up to 80. Why? Because we got together, we collaborated, and we talked about what could we do to get patients to fill this out. So iPads. We brought the iPads to the patients, to the room. We had one person coming in and talking to them about the survey and helping them. Literacy, making sure it was in their language.
Right.
Translation was very important. That was something that we set up here at St. John's. I don't know what I would do without it right now.
Yeah.
I'm using it with just about every patient. There's nothing better than to have experienced people. Not that we didn't have translation before, but sometimes it was pulling in staff. Now we have experienced people talking.
We have a service too. So
and that's the service that I'm talking about. And this service we're able to use so that if they have questions, we can bring the phone right to them.
Right.
And they can speak to the phone and they can answer the survey. So the survey is about what they report. It's about their experience. And then we take the information from that and we extrapolate, and then we can see how we can improve ourselves.
Right.
And from that, we have formed other initiatives, which I'm sure maybe you'll get to, that can even more help us in terms of the patient experience, because it's all about the patient.
Well, it is. And actually, that's a beautiful segue that you just handed me. Thank you very much.
You're welcome.
So there is something that's coming in the future that all patients will be partaking of, but it is something called teen birth. Can you give me a description of what that is without going into too much detail, because we are going to launch that officially. And I believe we're the first hospital in New York.
First hospital in Westchester.
To
do this teen birth, which is a Harvard program that we're bringing. And this program is, again, about patient-centeredness and bringing the care into the patient's rooms. So what it's all about is huddles. In brief, it's huddles. We huddle in front of the patient. We talk to the patient about what they want in terms of their birthing plan.
And that includes the significant other, the partner, whoever's there.
Doula, if they have a doula there.
Right. The nurse,
midwife,
the doctor.
The nurse, the doctor.
That's beautiful.
PA, anyone who's around comes into the room, and we have boards. We're able to talk to the patient about what they want and then execute the plan.
So maternity here has really come a long way. Although we've been in this business a long time.
Yes, we have.
And interestingly, recently we're hitting somewhere over 131,000 births at St. John's.
That's
amazing.
That is amazing.
Yeah. I contributed to.
That's right. Yeah. And I contributed to as well.
There you go.
And I was here for the 100th.
And yes, you were.
So it was my colleague that delivered the 100th baby, Dr. Motley.
That's right, the 100,000th baby. So, maternity has been a big focus for us, and we're so thrilled that, you're all working on this and helping to improve care for our community. So I thank you so much for sharing all this great information with us today.
It's great speaking to you today.
Thank you. And thank you to our audience for joining us today. We'll see you again real soon.